has really been happening on our own scene. And if you just look at this comparison between the last, okay, let me go one side of it. Right, between, I'm not sure if you can see this clearly, but between September 13th to March 13th, and September was our last surge, we had 162 cases in being confirmed positive in a 24-hour period. Currently, we're having over 587 cases confirmed positive in that 24-hour period. And our death rate definitely has increased. At that time, we were having, a few deaths here and there, and the overall numbers were not so bad. But when you look at what is happening now, we're having between tens, in the tens to teens minimum on a daily basis. So we've definitely seen a marked increase, and COVID fatigue is a real thing for a lot of our population. People want a break and they want to get out of their masks and they want to go back to normal life. And I know all of you are feeling the same thing. So that's a bit of where we're at. And awesomely, we are starting our vaccination procedures since last week. So we're hoping that by the end of this month, we have gotten somewhere between 50 to 65% of our population vaccinated. It's a bit ambitious with the staffing that's available, but we're really hoping we do get there.
Thank you, Dr. Pate Robinson. Do you think, well, I guess we're going to wait for anybody else has any questions. If not, I'll start.
Yes, please go ahead. We don't have any in the chat box.
Okay, do you see, I think the new strains that we're having now has a much higher mortality, and you think it is a lot more infectious. Sorry.
Definitely.
Yes. Do you have any idea what we could possibly think it is? Because somebody said to me they thought it was more like the Brazilian.
It's kind of hard to say. One of the things that's been difficult for us to track is getting the travel data to compare with our medical and clinical data to see what the risk factors are that we're looking at. In terms of traveling to the island, we have so many visitors from all over the world that it's harder to gauge where our high risk areas are and whether we should. I don't think at this point we've seen perhaps a lot of travelers from, say, South Africa, but we do have a lot of traffic between here and the UK, between the States, the United States, where many of you are. We have a fair amount of traffic through Central America, partly because of where flights are able to come from and where there have been travel bans that have affected how people get around. Not as much from South America, but we do have a lot of connections with Latin America. And so we're still not sure where our new strains primarily might be from at this point.
And we still, as far as I know, we still don't know when we will check if we what strains we have. Is that correct?
Not yet. We're trying to increase our in-house capacity. We have the machines, we have the capability, but sometimes the funding to get some of those things done, to have the appropriate reagents or chemicals, can be a little bit slow in coming. I know they're really working hard to get that done.
Dr. Dawes, may I ask you a question?
Sure, go ahead, Dr. Maxey.
Early on, I think the number of cases in Jamaica was lagging behind what we have in the United States, and some of that was attributed to the fact that there was a good natural food sources that had a lot of essential elements in it. So before the surge, is that still helping the population, the indigenous population? And if not, why not? And why are you letting all of these travelers in from other hotspots? Why aren't you stopping some of that?
So in terms, I'll try and take that in bites. In terms of the food sources and, you know, eating organic and so on, the majority of the population do eat a fair amount of unprocessed foods, which is basically organic. But in terms of that being a protective factor, I don't think we have enough evidence to say that it is or it isn't. What we know for sure is that this time around, there is so much of a decreased perception of risk, I think I would have to call it. You know, if you think that you are safe in your family setting, then you don't use a mask, you eat together, laugh together, and so on. But that doesn't always take into account that, okay, maybe one or two people in the family are going out into the general population, coming into contact with a lot of people, may not be wearing their mask properly. People tend to wear it here, you know, below the nose or under the chin or on the head and all of these things. And so sometimes we perceive ourselves to be less at risk. And I think that's giving us a bit of a challenge. And there are a lot of cultural differences that have an impact. There are a lot of beliefs against COVID being real in some segments of the population. And there are beliefs that are counter to the benefits of vaccines and vaccination. So we are fighting a big battle with that. You had a second part to your question that I don't recall. Could you remind me,
Um,
Dr. Maxey?
yeah, the second part, and I'm going to add a third part now. Why are you letting in people from the United States and other hotspots if, in fact, your statistics are much better than ours here? And also, I'd like to know how you're treating patients uh, pre-vaccine, either at home or in a hospital. What protocols do you have?
Okay. So I think the countrywide lack of a shutdown at the moment is about our economic survival more than anything else. We are resource limited, as many regions of the United States and many other countries are, but you know, being an island nation with very limited resources, we depend, and having heavily been dependent on tourism in a lot of ways, not being an industrialized country primarily, then closing the island to travelers is a big decision. It's been done before, it will likely happen again. And there are a lot of screening protocols in place, but the government is trying to balance carefully between two very, very tall cliffs. So we are expecting that there will be some more stringent measures coming by the end of this month. And we're not sure how long those changes will last. But we had a short reprieve, I think, to see if people could really engage in good protective behaviors and stay the numbers, but that's not really working out. So things will likely change very soon. In terms of how we're treating people, I don't know how much you've been following the evidence for the different treatments that have been tried internationally, but there have been a lot of potential treatments that haven't really panned out in terms of their effect to actually limit the spread of COVID-19 virus, to limit the severity of infection, to limit death. And we have found in our own personal experience that the anti-inflammatory treatments that are also the mainstay or the backbone of treatment in a lot of countries are really the things that have the greatest effect so far. Things like steroid therapy and supportive measures. It's harder for us to appropriately use some of the antiviral drugs that have been tried, like remdesivir, because our people tend to come in after the time period or be identified as positive after the time period where those drugs would really be useful. So people still use them, but they're not really being used at the point where they would have their maximum effect. And we have a number of people trying things like the Actemra, the tocilizumab, that has had some small utility and benefit for us. There have also been people using the antiparasitic agent ivermectin, and that's not necessarily approved for use, but we're allowed to use it off label in some ways. And so there are some people trying that out, and some are reporting good benefits, some are not sure. So for the most part, it is a lot of supportive therapy and things like high flow nasal cannula oxygen therapy. That's like the best thing since sliced bread. For those who know what hard dough bread is. But that and getting people to prone or to breathe more on their chest or tummy has been something with physiotherapy that's made a big difference to how some people have pulled through.
Thank you.
We also add the extra vitamins. I had the
Yes.
COVID ward at my hospital, which isn't part of my resume, and do infection controls. So we also do the extra vitamins. I know it has been talked about in um, on this lecture beforehand. So we also add that to everybody else that comes in. I know Remdesivir was short because I admitted somebody a few days ago and the whole island was out. We are also running out of oxygen right now. In fact, they called me several times this morning, um, because it's an island-wide problem right now.
Yes. Definitely the vitamin D and C and zinc and some of these other things. Some people are utilizing more lemon and turmeric. And so that's definitely happening very widespread across the board.
And we do use off-label ivermectin off and on, depending on, yes, on the consent, yes. Basically, because we don't have the monoclonal antibody, we don't have a lot of access to all of it. I mean, that patient for the Remdesivir is a multimillionaire, and I couldn't get it in time. In fact, we're flying him out of the country today. When I get off the call, I hear there's some hiccups. So they were calling me a while ago.
So I'd like to ask Dr. Pate Robinson about what's going on in the pediatric population. Are you seeing the same kinds of late onset, sporadic cases? Are the kids by and large not, for them, if they do become infected, are they asymptomatic? And are your schools closed?
So we're not seeing a lot of childhood infection. We're not doing as much childhood testing as well. So we don't have perhaps accurate numbers of that. But the children that we have seen come in who are tested positive, for the most part, have very mild nasal or upper respiratory symptoms. They may have a little abdominal pain. One or two might have diarrhea, but they tend to resolve pretty quickly. And the main challenge is keeping them feeling okay during their isolation period, because that is a lot harder for a child. In terms of that, I would say that we've had very few numbers and nobody with any delayed response that we've identified so far from a pediatric perspective. We have, I think, about 25% of our tested antenatal cases are positive, but also in the antenatal population and the postnatal population, symptoms are very rare. And so between the children and the pregnant mothers or recently pregnant mothers, we really don't have significant disease from a COVID perspective. In terms of the schooling, we had some phased reopening and then had a few outbreaks, some at boarding schools, some at other places. So schools were closed again. There are very few that were reopened for face-to-face teaching with significant precautions in place. All those closed again, but there is going to be some reopening from the perspective of the exam groups, because our system being a British system, we have very serious exams that have an impact on their moving forward from a future perspective. So I think our 8th, 9th, 10th graders and 11th graders, there are a couple year groups that have very important exams coming up in the next few months. And so once their schools are cleared to readmit them for face-to-face classes, they will be going back to face-to-face.
Well, thank you so much for your perspective from Jamaica, and we hope that you can stay with us throughout the program for additional questions. But at this time, we're going to move to our next guest,
Thank
who
you.
is Ms. Patrice Russian. Ms. Russian,
Hello, great to see you all.
how are you?
I'm well, thank you. Thank you, doing fine.
Ms. Russian, do you want to introduce yourself, or do you want me to tell our audience a little bit about you?
Oh, go right ahead, please.
Okay. Miss Russian is an award-winning musician and classically trained pianist who originally found success in the 70s and 80s with her signature fusion of jazz, pop, and R&B. During this era, she composed and recorded the hit song Forget Me Not, which was frequently covered and sampled by other artists. Miss Russian is also a four-time Grammy nominee who has composed scores for movies and television. She has been the first female musical director for many of the entertainment industry's top award shows, which include the Grammy Awards, the Emmy Awards, the People's Choice Awards, the NAACP Image Awards, and HBO's Comic Relief. Considered one of the world's top jazz pianists, she has performed with many artists, among them such as theme names as Stevie Wonder, Herbie Hancock, Prince, Nancy Wilson, Indigo Chandler, Carlos Santana, Christian McBride, and Lee Ritenour. She is a record producer and an award-winning composer of symphonic music, some of which was commissioned by the Detroit Symphony Orchestra. Ms. Russian is the ambassador of artistry and education at Boston's Berklee College of Music and is the chair of the popular music program at USC's Thornton School of Music. Ms. Russian also spends time working with the Los Angeles Cultural Affairs Department, the NARAS Grammy in the Schools program, and other organizations dedicated to establishing music education and mentorship programs for underprivileged youth. And without further ado, I turn it over again to Ms. Russian.
Thank you very much. Great, as I said, great to see you all. In this era of COVID, one of the things that I think sometimes, I don't think it's overlooked, but we don't necessarily think about it with so many pressures and the difference that the pandemic has made in all of our lives, and as professionals, that there are also some major things happening in every aspect of our professional lives, and the arts are affected. The arts are affected as well. So I was asked to just kind of speak on how the pandemic has altered or changed the reality for those of us who are music makers. Certainly from the standpoint of the most obvious is that we're not playing because all of the concert venues and clubs, have had to close. And so it has presented some very interesting challenges for all of us because the performing arts, music being one of them, depends on us being with each other. Our music and what we do as a collective activity in order to bring, music to people is just not something that we had ever thought that we would have to find other ways to figure out how to do it. We love playing, and people who have dedicated themselves to music have spent hours and hours practicing in order to be able to play and do things that not only give the artists pleasure, but also bring a certain amount of pleasure and cultural awareness and identity and conversation and provocation of concepts and things like that. That's what the arts are, and that's what we're taught our role is in society as artists. So it's been interesting for all of us to be able to talk about it, and thankfully, um, through the medium of Zoom and other technology, we are able to at least talk about it among ourselves and figure and hold each other up and figure out other ways to continue to keep the music going, because that's our lifeblood. Some of those ways in which we have done that is to get together and just talk. And it's been amazing because the idea of the thing that you typically would roll to as your sanctuary in your music making, to be in a situation where the pandemic and the fatigue, you know, as has been mentioned, that goes along with that just psychologically. You don't feel like writing any music. You don't maybe feel like even playing. And it's scary because those are the things that you love to do the most. So, but getting together as a community to be able to talk about it has been very, very helpful for us to share ideas, share with each other the music that we love, keep each other inspired and motivated to keep trying. And for me, myself, I have used a lot of that same kind of connectivity to reach my students. Those students of the arts are the ones that are, all of the students are suffering some, and certainly Zoom fatigue is there, but the students in the arts are suffering because there's only so much you can talk about. You have to do, you have to physically do things, you have to play, you have to, even in the music lessons. I mean, can you imagine teaching someone piano or teaching someone composition, and you're working and all you want to do is reach in and move their hand to the left or to the right for possibly a game-changing technique for them, but you can't do that. And talking about it with other educators, we've started finding ways to be able to get the students playing again. Not in real time, but because the technology is not quite there yet, but at least giving them opportunities to be able to use something as simple as an iPhone and go and learn software that gives them access to being able to record and then pass their recording on to the next person in their group or in their band, so that you wind up with a recording of everybody playing together. It teaches personal responsibility. It teaches some of the other skills that come out of ensemble work and ensemble playing. Teaches you precision, helps you with time management. And the end result is a performance. Again, not in real time, but there is a performance, and that aspect and keeping that aspect sparked and kindled in our students has helped them a lot. There's a bright light at the end of the tunnel, though, as we hope that we're reaching an area where we can all see the possibility for the end of this pandemic. And a lot of our professional performance spaces are opening up in a way that allows for, and I'm speaking of recording studios and rehearsal studios, to be COVID compliant. 6 feet between any two performers, plexiglass between performers, masked, shielded, especially if you're singing with the aerosols, et cetera. There are special masks being made for horn players so that they can actually play but stay masked and keep their levels of saliva and spit relatively close to themselves and with a shield. So we're finding ways to do that by integrating the larger professional community with the education community, music education community, so that the students have access to some of these venues that are COVID compliant, so that we can get people playing and playing together. And I see that as really good news, not only from the standpoint of the music making and the obvious joy that it brings the students to be back in their spaces working and learning together, but the ones that are not as obvious, and that's the psychological impact of the thing that you love, not being able to do it and not necessarily being able to see how you're going to do it. So that's been nice to see, and very, very positive. And, we're looking to try to continue along that path, both on the professional level and also on the student at the student level.
Thank you so much. We have a special surprise for our audience, and that is we're going to have a sample of your beautiful music. Again, we want to thank you for sharing your thoughts and experience in this pandemic. We're all in this together, and it's good to hear how different people are experiencing the pandemic. So thank you again.
Thank
So,
you.
okay, Simon, let it roll. Well, I think we were all floating away to a beautiful place listening to that. Thank you again.
This is just I just have to step in and say, Ms. Russian, I speak for probably everybody on this meeting who has been a big fan for a long time, and just really appreciate what you do, and also appreciate so much the teaching that you do. There was a question in the chat about using music as therapy. I remember a friend growing up in Southern California who attended the music therapy program at Long Beach State. And I know other places have music therapy programs. Can you talk a little bit about music as therapy?
Absolutely. Uh, it goes back to the beginning of time that frequencies of sound have an effect on your psyche and have an effect on your physical body. And the arts and music as we know it just organizes frequencies of sound, and usually in a pleasurable way hopefully to be able to offer just what you just described just now, to be able that the music itself can lift you. It can take you to a place. Our African American culture certainly it saved our lives. From the standpoint of as far back as you can think. It's slave trade and gospel music, all of the different musics that have come out of for example, the African American experience. you know that power that music has to be able to move people. The arts are what makes us human. It separates us from all the other species. So it just to your point, it goes without saying that um as we have continued to study music's power and its emphasis, we've it's taken us back to look at how it has affected healing,
Mhm.
as it has affected people's ability to focus, to concentrate, to calm down, or to get motivated. And now those studies have led, in most contemporary music schools, to a degree in music therapy. So it's used to be able to work towards all kinds of areas of cognitive thinking, critical thinking, as well as being able to primarily be used to help people to settle and to find that place in themselves where they can calm themselves to be able to rest or be able to think more deeply. So we're still learning a lot about all of the different uses for that. And what's great about that, beyond just what we know are going to be therapeutic uses, is that it opens up the idea also that the music industry is not all about the one who's singing in front of the mic all the time. It's also about all of the other aspects and elements and avenues, and particularly uh, the power and importance of music. It's fun and all that. Don't get me wrong. A lot of great uh, things come from being able to do anything really, really well. But one of the things that we are also emphasizing these days is the responsibility of the artist to be able to contribute to society and use their art to do that. And music therapy is one of the ways that we offer it now in terms of a degree and an opportunity.
So thank you again. I just wanted to highlight one of the areas that you touched on. Music is also for a lot of people, and I know for me, it's a place of safety because there are times when I can put on a song that will take me back to how I used to feel or a place where I was. And so music for many of us can be literally that escape. And during these times when things are so challenging with pandemic fatigue and all the loss that we've all experienced, I just want to say thank you to you and all the other artists that give us that place where we can escape, even if it's only for 4 to 8 minutes. It can matter. Thank you so much.
Thank you.
Thank you. And now, Dr. Kervin Dawes.
Okay, now we're going to welcome one of my best friends, Dr. Michael J. Corin. He practices as a cardiologist and a certified physician investigator. He is CEO for the community-based multi-specialist Encore Research Group that operates in multiple sites in Florida. Fellow and two past presidents of the Academy of Physicians in Clinical Research, and past president of the regional chapter of the American Heart Association. Served as an investigator in over 2,000 trials and as the international lead investigator for many multicenter trials, including Alliance, Role, Treat to Target, Osler, and Mendel studies. Written and co-authored over 100 peer-reviewed articles, Dr. Coren has also designed a clinical research training course for physicians now in its 20th year. He and his team study the research of research ways of improving site performance, recruitment, and operation efficiencies. These methods have taken form in the Clinisys, CTMS, and US patented Ask on 100 Doctors survey system. Welcome, Dr. Coren.
Well, thank you. Thank you for inviting me. It's always a pleasure and privilege to be part of this really interesting group of folks discussing very important and topical things. I don't know if this will work in terms of screen sharing, but I thought that a good way for me to present some information about COVID-19 vaccines today would be to share with you some of the highlights from a talk that I gave last week that was focused for people around the state of Florida. And I think although it was a Florida-centric talk, I think that the lessons are actually pretty relevant for people all over the country and all over the world. So I'm going to try to share my screen here and see if that works. And if the technology works, then you can see my slides. Is everybody able to see the first slide?
Not yet.
Yeah.
No? Let's see here. Screen share and screen share.
There we go.
Ah, there it is. It's always wonderful when the technology works, and everybody can hear me okay.
Yep.
Yes.
Okay. Well, it was an hour lecture, so I'm not going to go that long nearly, but I'm just going to create a little bit of discussion around a few highlights from this lecture that I think will be insightful. So let's see if I can get the slides to advance, then we'll be golden here. Okay. Alrighty. Let's see, we're doing screen sharing, and let me see here. For some reason, slide advance is not working. Oh, there we go. All right, I'm not sure why there was a delay, but anyhow, these are just some of the things. Actually, one of the interesting things is that we are starting to do hybrid meetings at our organization. So we're inviting people who have been vaccinated to actually share information in a live format. And for this particular lecture, we had about a dozen physicians in the room sharing information face to face, which was really just a welcome reprieve from I guess the Zoom fatigue and the COVID fatigue that we're all experiencing. So we both were able to discuss these data face to face and also project the information to a much larger virtual audience. So it's a nice format, and a format that we hopefully will continue as the numbers get better. But this is a slide that shows, as of last week, what the numbers look like in different countries around the world. And you can see that the US leads the world in the number of cases and the number of deaths, which is an unfortunate statistic. But what I was talking more about last week was some of the very, very interesting things across states. And these are the data for the most populous states in the US. And if you look towards the middle of this chart, which is highlighted now by my arrow, and you look at the per capita cases around different states of the country, you can find that the number is actually really, really consistent. It's about 90,000 cases per million people, which broadly is about 10% of the population has had proven COVID-19 infections. Now keep in mind that does not count all the people who have been infected that may not have tested because their symptoms are relatively mild. And as Dr. Pate Robinson, said earlier, kids tend to have very mild illnesses, and that's an observation around the US and around the world. And a lot of folks that have had low-level illnesses don't even get tested. But in terms of the number of people in different states around the country, about 10% of the population has been documented to be infected with COVID. And if you look at the large states, California, Texas, Florida, New York, Illinois, and Georgia, you can see the numbers are really, really consistent in terms of the number of people in each state who have been infected. but the death rates actually are fairly different. And so if you compare Florida at 1,450 deaths per million, that's actually significantly lower than the national average compared to New York, for example, that's 2,470. Now, there are multiple reasons for that. One, of course, is that New York got hit very hard early on before they had all the information about how to treat this most effectively, how to treat COVID-19 most effectively. But the other thing has to do with really the overriding important demographic element of things, which is that COVID-19 is a virus that disproportionately affects older people. It's something we're seeing over and over around the world. And early on in the state of Florida, the strategy was to keep commerce going, but to really lock down the nursing homes and to be very, very protective of older people. And you can see here that the strategy really did work, because we have in the state of Florida less than the median amount of deaths per million population, despite the fact that in Florida, we have the second oldest population of any state in the US. The only state that has an older population than Florida is actually Maine. And California, that has a significantly younger population, you can see has done better than the average. Texas, which has a younger population than Florida, has done a little bit worse. So this is a very, very interesting look at how the focus in Florida, which was to lock down the nursing homes and to really separate older people from other elements of commerce, was basically an effective strategy. And it gets a little bit just into Florida statistics, which I won't go into for this, but what we found, and this is also true in California and many other places, is that the numbers are coming down really, really rapidly. So the worst of the pandemic so far has been in that time frame at the end of December and the first week in January. So right around the Christmas holidays and in the very beginning of the year, we were seeing the highest numbers, and those have come down significantly. So in California, for example, the numbers are down 90% from peak. In Florida, the numbers are down 80% from peak in terms of the number of cases per day. The other thing that is probably incompletely understood is how strong this demographic issue is. So these are data from the Florida website that actually is really doing quite a nice job of keeping track of people. There's looking at the most important statistic, which is mortality per 100,000 population. And you can see, if you look for younger age groups, say 24 years or less, the mortality is really, really uncommon. In fact, the mortality rate is about 1 in 5,000 for those folks. When you get into the middle ages, like people in their 50s and 60s, you find that the mortality rate is about 1 in 40. And once you get into the 80s, you find the mortality rate is really, really high. In fact, for 85 and older folks, it's a quarter of all people who get COVID-19 will succumb to it. So this is really the most driving element of the demographics. And the other thing that comes up quite a bit is the difference between races. And again, in the state of Florida, and this is also true in other places, whites and blacks seem to be affected approximately equally at this point in the pandemic. This is just looking at the number of cases of mortality based on the number of people infected, just making that point once again. The other thing that we don't talk that much about is that men seem to do a little bit worse than women when it comes to COVID-19 mortality. And you can see these data from the state of Florida. And interestingly, there's this Hispanic paradox, is that Hispanic patients actually tend to have a higher likelihood of infection, but they have a significantly lower case fatality rate. Part of that is probably due to the fact that Hispanic patients that get infected tend to be younger. This is just making the point that I made before, is that the places that have the highest percentage of population over 65 years old are Maine at 20.6% of the population and Florida at 20.5% of the population. California is close to the national average of about 14%. So I'm going to move on to another point here, and just remind people that we now have 3 vaccines that have received emergency authorization. None of these, by the way, are fully approved. And that's an important distinction. So when something is emergency use authorized, it means that it can be used, but only through government means. The manufacturers cannot sell these products directly to physicians or healthcare entities. All of it is distributed through the government, and the CDC has the important role of making sure that there is a fair and equitable distribution of the vaccines throughout the country. Each state has used a slightly different strategy. The state of Florida, where I live, they've decided to hold back the doses of the Pfizer and the Moderna vaccine so that everybody that gets a first vaccine will have a second. Some states have chosen the more aggressive strategy of trying to get everybody to a first vaccine as quickly as possible. Recently, the Johnson & Johnson vaccine became available, and that will probably markedly increase the amount of vaccine available. And it has also some fundamental differences that are, I think, actually exciting and that should have a big public health impact. So just to remind everybody, the Pfizer vaccine and the Moderna vaccines, which received emergency authorization back in December, use the messenger RNA platform, which is basically messenger RNA that is put into a lipid micelle that's injected into a muscle. And that messenger RNA will ultimately get into the cytoplasm of cells and induce that cytoplasm to produce parts of the spike protein, which will elicit immune response. The Johnson & Johnson strategy is actually to use an adenovirus that's not able to replicate itself. And it substitutes some of the genetics of the adenovirus with genes that make COVID-19 proteins. And the adenovirus will get into the cells. They actually do get into the nucleus of cells, and that will induce cells to produce some of the spike protein elements that will ultimately create an immunity. So one of the very interesting things about this and some of the debates and discussions is that because the Johnson & Johnson product used the adenovirus vector, and for those of you that are not familiar with that term, vector is the means by which the genetics are presented to our system. So a vector is typically an organism that brings some other biological material into a host. And in this case, it's an adenovirus it's a vector for the genes that will produce a spike protein and ultimately produce immunity to that spike protein. Now, because Johnson & Johnson uses an adenovirus and because adenoviruses are using DNA to express their messages rather than RNA, we have different storage requirements. RNA is something that actually is a fragile molecule, which is both good and bad. It's good in that it doesn't stay in our system very long, but it's bad in that it gets degraded very quickly. DNA tends to be a much more stable molecule. So the RNA vaccines require either freezing or deep freezing to keep their stability, whereas the Johnson & Johnson vaccine can be refrigerated for an extended period of time, which makes it easier to use and distribute. The other advantage of Johnson & Johnson is the fact that it's a single dose vaccine. It was developed as a single dose vaccine. And because of that, it actually has some consumer preference. I'm seeing amongst my patients that many of them are actually just interested in getting one shot and being done with it. The disadvantage of the Johnson & Johnson vaccine is that the overall efficacy number tends to be a little bit less than for the messenger RNA platforms. So in the messenger RNA platforms in the clinical trials, we're looking at efficacy rates of about 95%. For Johnson & Johnson, we're looking at efficacy rates of about 70%. The other thing that was interesting about the Johnson & Johnson vaccine is that it was studied in South Africa, where we had the variant that was mentioned previously, the 1.351 variant, and also in the UK and in Latin America. So we are seeing that there is reduced efficacy of the vaccine with the variants as compared to the wild type COVID-19 virus. But the good news is that severe cases don't seem to be that different between the wild type virus and the variants. The other little interesting tidbit, it's really more trivia than anything else, is that the Johnson & Johnson vaccine was developed in conjunction with Beth Israel Hospital in Boston, which is where Lisa and I became really close friends. We worked together as medical students there for 3 months. So it's a bit of a bonding experience for us personally, and something that's kind of neat to see that the labs that we worked in as medical students were very involved in getting this important product to the market. Also mentioning that there are other vaccines that are approved outside of the US, and these are just a listing of some of them and what the efficacy results have been stated. Keep in mind that some of the other vaccines, particularly the ones that are produced by China and Russia, have not been subject to the very rigorous clinical trial testing that we are used to here in the US and in the West. So there has been a little bit of skepticism about some of these numbers, but these are what's been reported publicly. So, and I'll just very briefly say that there's another vaccine that we've been working on called Novavax, which is actually giving a stabilized spike protein rather than instructions for our bodies to make the spike protein. And we are rapidly involved in clinical trials with this particular product, and we anticipate that this will get emergency authorization. So in the interest of time, I am going to skip over all this, except to show you 3 quick pictures. This is the Kaplan-Meier curve of the Pfizer program, showing that about 7 to 10 days after the first dose of the vaccine, there's a dramatic separation of the curves. And you can see that in the red, that people are still, in the placebo group, in the red, people are still developing the infection in a linear fashion. Whereas after the first dose of the Pfizer vaccine in the blue, there are very, very few cases. Similarly, for the Moderna vaccine, we see the same thing. Again, a separation of the curves after about 10 days. And both these graphs come from the FDA documents that were circulated publicly, the briefing documents that get circulated before the advisory committee makes their votes. And finally, the Johnson & Johnson is also showing a similar efficacy rate. Maybe a little bit delayed, the curves start to separate at 14 days after the vaccine. But again, very impressive difference between people who in the red group got the placebo and the blue who received the actual vaccine. So again, in the interest of time, I will leave it at that and be happy to entertain any questions, except to say that one of the big questions that was brought up is when we get to herd immunity. And I've studied this pretty carefully in the state of Florida, and we're getting pretty darn close. So just to give you a little bit of a sense, we know in the state of Florida that there are 2 million people who have had a PCR documented infection, and at least 2 million who are probably been infected but didn't get tested. That number may be more. We now, this is actually from 10 days ago, we now have 4 million people vaccinated in the state of Florida, including about 75 to 80% of people over 65. And so as of 10 days ago, this is about 7 million out of 21 million. Now I would say we're closer to about 10 million out of 21 million Floridians are immune, either based on vaccination or based on the fact that they've survived COVID. So that's encouraging. I think with the increased distribution of vaccines through now the Johnson & Johnson product availability and the increased availability of the Pfizer and the Moderna products, I believe that there's a very good chance that about 70% of Floridians will be immune by the end of April. So that is a really, really nice note and a somewhat optimistic note. And I am actually fairly optimistic that by summertime, we'll have a sense of normalcy in the US and hopefully other parts of the world. So I'll stop with that and be happy to answer any questions.
Dr. Corin, I was interested by a lot of what you said, but in particular, there were a couple of things that you pointed out early at the beginning of your presentation.
Mm-hmm.
You
Yes.
talked about where we are now with it looking like, at least for now, we are seeming to improve. Would you please comment on, I mean, we don't have any data yet, but could you comment on what you think the impact of the variants might be on our ability going forward towards getting the pandemic under control? And then the second question, and I was very intrigued by this comment, at this point, there seems to be an equal impact of disease on both Blacks and whites. Now, we've had all kinds of conversations in the past as to why the Black community is disproportionately impacted. Why are we now evening out, and what can we do to accelerate that or support that trend toward being less disproportionately impacted, if in fact that is what we're really seeing?
Sure. Yeah, both excellent questions. So the variance is the real wild card in terms of how quickly we get through the pandemic. And on a positive note, we have now a fair amount of data from the Johnson & Johnson study and a lot of epidemiological data showing that mortality rates, for example, in South Africa and in the UK are not really different than in other parts of the world. So in terms of the actual mortality epidemiologically, I think that the variants seem to be similar to the wild type virus. And keep in mind, this is pretty much expected. We know that viruses mutate, and particularly coronaviruses mutate. So it's not unexpected we're seeing the variants. And the data from the vaccine studies also show that although you may be able to grow COVID-19 from the noses of people a little bit more easily if they have a variant rather than the wild type, they still tend to not die or get really, really sick. So there is a protective element of the vaccines, even if you're able to grow the virus, which is growing the virus is how we judge efficacy in the studies. But at the end of the day, we just want to keep our patients alive and healthy as much as possible. So the vaccines are still working for the variants is the bottom line. And the South African variant, which seems to be the one that's the most resistant to the vaccines, isn't widely prevalent in the US. In fact, in the state of Florida, I haven't seen any reports of it being identified. I know there are parts of the country where there have been some limited pockets of it. So keep our fingers crossed, but so far so good that the variants don't seem to be a big problem, but that is a very, very important thing to look out for, and hopefully something we'll be extremely vigilant about. As far as the racial differences are concerned, every virus is different, and biologically, this virus affects all races pretty equally, is what the data are showing at this point. Obviously, there are socioeconomic issues in terms of exposures, and I think that's what we're seeing early on in the pandemic. But when you look at the actual biology of the virus, it's older people just do worse, and Black, white, Hispanic, Asian, it doesn't seem to matter. If you're older, you do worse. Younger people do better of all races. And as we get more and more data, that is the dominant demographic issue with this particular virus. This, by the way, is very different than what we saw during the Spanish flu pandemic 100 years ago, where younger people were disproportionately affected. For whatever reason, for that particular virus, there were some reports of a 7% mortality rate amongst young, healthy military recruits. And we're not seeing that. Teenagers seem to have very mild illnesses for this particular virus. And at the end of the day, the virus seems to affect people biologically about the same. Obviously, there are socioeconomic issues that we talk about and that are important, but biologically, they really, really look the same across different racial groups.
Dr. Corin, may I ask a question? This is Dr.
Sure.
Maxey.
Yes, sir.
In regard to what you said about the equalness of the infection, I want to speak about one, the equity of the infections. There was information put out before that Blacks were about 2.9 times more likely to have COVID and have mortality. And there was an increased rate in also Latinx people and also older Blacks. In addition, there was the statistic that those who could not have the type of job that didn't make them essential or go out, is it or is it not disproportionately affecting communities of color, both in terms of infection and in terms of death? And then specifically in terms of how the Florida government has chosen to distribute the current vaccines to the population in Florida. It's been said that if you give everybody, every community equal, it's not equitable for communities of color.
Sure. Important questions, and thank you for those questions. So the data are pretty clear at this point, and I review them very, very carefully, virtually every day for the state of Florida. And I also look at certain other states, including California. In the state of Florida, the mortality rate per 100,000 Black people, 100,000 white people is exactly the same. There's no difference. So and that's the most important statistic. Getting to the other points that you made, there is still more vaccine hesitancy amongst Black populations as compared with white populations. But fortunately, older people in the state of Florida have adopted vaccines at very high rates in different communities. There is a little bit of a difference. So in communities that are more communities of color, the vaccine adoption rate is about 10 to 15% lower than it is in other communities. but it's something that is being worked on very aggressively. But the bottom line is that the actual number of people who have died is similar between blacks and whites. In California, which I've studied also, Hispanics have had the disproportionate number of cases. So in California, Hispanic population is approximately between 40 and 45% of the total population. And they've had about 63% of all COVID cases. Black population in California is about 8% of the population. And the mortality statistics are pretty much on track for the percentage of the population. So that, I see that as good news. I do see that there are these socioeconomic issues, but one of the things that has mitigated the socioeconomic issue is the fact that this virus seems to not impact younger people as much. So a lot of the socioeconomic issues are also related to younger people and higher exposures, to the point that you made, Dr. Maxey, people that have to go to work, that have types of jobs where they're more likely to be exposed to other people. So there's no doubt that there are socioeconomic issues involved, but fortunately, when it comes to mortality, they don't seem to be different between blacks and whites.
Thank you.
There is a question in the chat box asking if there has been any more data supporting the observation that certain major blood group types may be more at risk for COVID-19 or its complications than other groups. And I think they're referring to the information that was out that O positive individuals were less likely to become infected or more, or would be less severely ill if they were infected. Are you aware of any new studies discussing that?
Yeah, it's a really interesting question, and I've heard that question before. And I actually asked the folks that are involved in the clinical trial to see if they can study that. Blood typing is not something that we typically do in the clinical trial, so we don't have ready data. But one of the incredible, valuable sources of information are these clinical trials. And that will hopefully be a place where we can look at very carefully infection rates based on blood types and also how they interface with vaccine use. So again, the information I've seen on that so far has been more anecdotal, but the clinical trials will hopefully at some point be able to give us more solid information about that.
Dr. Corin, when, as a former state health officer, when I have to go out and actually do public health and talk to the public, some of the questions they ask aren't really so much based on science and data, but they ask very practical questions. So for example, Monday, Tuesday, Wednesday, Thursday, everybody is saying African Americans are dying at higher rates from COVID-19. It's hitting this population more. That message has been a clear message that no one has really argued with for months and months and months. So that's Monday, Tuesday, Wednesday, Thursday. So now on Friday, we have a clear statement with clear data that shows the incidence of mortality is exactly the same. And the obvious question from not from so much a doctor and scientist perspective, but a regular person perspective is, what do you mean? So was everybody else wrong? Were they not doing math correctly? I think as scientists, as things change, we are very good about giving the new information. And where we lose the public sometimes is we don't tell them enough about how we got from A to B, like show your work. So I think somebody out there, me, is asking, how did we get from everybody saying it was different to now you saying it's the same?
Yeah, it's a great question, and I'm with you. And as you well know, we haven't over the past year necessarily always done a great job of being data focused. And I say we. Some of that is media, some of that is politicians, some of that is scientists, maybe not expressing the data as well as we possibly could. But you make a great point, which is that there's a certain messaging that occurs, and it may or may not be equivalent to what we're seeing data-wise. And and how do you go about that? And that's why this particular forum is important, so that we can start to share that, but also use it as a way of helping people understand that we're tracking these things very carefully and that we're reacting to them. And if we see something, we're going to do something with these data that will make a difference. So when I look at the data now, just from a very pragmatic standpoint, I see that there is a little bit of difference in terms of vaccine acceptance between the Black and white communities. And that's something we need to work on. And we have done that in our local area. And this forum helps us do the same, is by getting people educated about it, particularly older people. We need to make the important point is that we need to protect older people of all races. That is the key vulnerability, and that vulnerability is so much greater than other things that can separate human beings. So again, your point is correct that there's been many opportunities for different folks to be more data driven in their communication style and to share this information. But there's also, I think, a nice message, which is that there's a unifying element of this, which is that this virus is absolutely devastating as you get older, and collectively across backgrounds and races and interests, we need to protect people who are most vulnerable.
If I may follow up on Dr. Walk's comment and question and yours, one of our presenters a week or so ago presented and said there is not so much a problem as a vaccine hesitancy for African Americans, but rather one of availability to our community. And he implied, and I actually saw in action, that the sites that were in Black communities are being overrun by people from other communities. So it's not as available to those communities, even though there's a high demand. And the other one that I want to tag on to that, CDC put out new guidelines in the past few days, suggesting that people who are vaccinated can gather more privately. But could you address both of those? Because there seems to be confusion, especially with the new directions from CDC. And I know we also have another one of our experts on, Dr. Despani. I'm very curious about your take on CDC and the availability versus the hesitancy in Black communities.
Sure. Yeah, great questions. And thank you for those questions. Yeah, I'm with you 100%. I think the CDC took a baby step by saying that people who are vaccinated could feel comfortable congregating with one another. And I think that's a very important message that needs to be elevated. And we have a lot of data now to show that people who are vaccinated have a very low likelihood of spreading it to others and are safe with each other. And that message, when you repeat it over and over again, will, I think, be the strongest way of overcoming any vaccine hesitancy. So that's, as I started my comments, I talked about the fact that we had a hybrid meeting, that we invited physicians to come to our clinical research center to congregate with one another. We served wine, we had a nice conversation, we asked questions around the round table. We had really a tremendous interaction, and then we projected that to the rest of the world, in part to make the point that these vaccines are just a tremendous breakthrough, and really, at the end of the day, the most important way to get over the pandemic. So again, positive reinforcement, the more positive reinforcement, the better. I was happy to hear what CDC had to say. I want even more. I want people to talk about that it's safer to travel if you're vaccinated. There are a lot of benefits to resuming a normal humanity that come through vaccination. And I think that's the most important part of overcoming the hesitancy. And then you make up a really interesting point about access to vaccines. And your anecdote is spot on. And this is where knowledge is power. So people who were reading about the vaccines, that were excited about the vaccines, a lot of patients of mine, and I have patients of many different economic and socioeconomic backgrounds. You can see the differences. The people that were doing the reading, that were studying, that realized how good these vaccines were trying to figure out how they can get it one way or another. So they would go to different neighborhoods, wherever they could get it, they would get it. That's where knowledge is power. So we are empowering the African American community by helping them understand how amazing these vaccines are, and that they should be as aggressive as everybody else to get them. And I've challenged a lot of people on this over the course of the last 2 months. I want to see the vaccine acceptance rate equally high. Now, having said that, it's actually pretty good. It's gotten a lot better over the last few weeks. And in the state of Florida, which I study very, very carefully, there's not that much of a difference now between the different racial groups, but there's still a difference, and we need to keep on working on that.
You know, Dr. Corin, I think that there are a lot of comments in the chat box around the way you are, what your data is and how you are analyzing it. But I want to make a comment before we get into the data question about this access issue. The issue with access is not just acceptance. We have had a number of speakers from around the country over the last couple of months since the vaccines have been released, identifying distribution issues that are being created by access. So, and we have Black community residents attempting to get the vaccine, but running into very significant barriers to obtaining the vaccine. So yeah, there has been a lot of concern about vaccine hesitancy, and rightfully so, but we are also seeing and experiencing across the country, in Florida as well, issues with being able to access the vaccine, either through the process of registering to get the appointment, or where the physical locations are where the vaccine is being distributed. So I do think in all fairness, and there needs to be balance, there are still significant issues that are beyond that of hesitancy impacting the access of the African American communities to the vaccine. But I want to go back to the issue of the data. I don't remember, and the slide is not up, but can you comment, when you're looking at the data and coming to the conclusion that there is equal mortality at this point, are you speaking in terms of rates per capita or absolute numbers? Because I think, as Dr. Walks was alluding to, there are different ways the information is communicated. And I certainly, and there's several in the chat, comments in the chat, wanting to know how you are slicing and dicing this data, because it is not squaring with the data that's coming from CDC and other sources. And if you're focusing on Florida, as you would, because you live there, you are certainly aware that there have been significant data integrity issues in the state of Florida. So if you're basing conclusions on the Florida data, what have you done to make sure that you have been able to overcome those data integrity issues that has plagued Florida?
Yeah, all the information from the different states ultimately goes to the CDC. The states are actually doing a better job than the CDC at keeping these things up to date. So if you look at the state by state data, you'll find that they're way, way ahead of the CDC data. And so that I track it on the different state websites, and I'm seeing the same thing in Florida and California and Texas and New York. Those are the states I kind of go to on a regular basis, and Florida's data has actually been really, really good. Answer your question, this is per capita. So mortality between Blacks and whites is equal per capita. The infection rate is slightly higher in African Americans compared to whites, but because the median person who's infected in the African American community is younger, the mortality rate's identical. And as I mentioned, there's a paradox in the Hispanic community, and this again is true in California, true in Texas, true in Florida, we're all states that have a significant Hispanic community, is that the rate of infection amongst Hispanics in all these states is higher, but the mortality is lower because they tend to be younger. And again, the driving factor in this is age. So that the data I think are very, very robust. I know that the message is different than what we've heard. And to Dr. Walk's point, you hear this message over and over again, and people aren't actually looking at the data. But these are per capita data. At the end of the day, this is a virus that doesn't care what color you are. It affects us all. And so again, my point has been this should be unifying, and that's how I go about my business when I share this information, is that we need to continue to educate all people. When we see groups that are less likely to get the vaccine, we need to ask questions as to why. If there are any barriers, we need to overcome those barriers. And working together, we will get there.
This is Dr. Walks again. Dr. Corin, thank you for taking some very tough questions. I like to state the obvious, and it has to be a challenge to not look like a Black person and come onto the Black Health Trust and tell us that so much of what we've heard is in fact different. Let me put one little cap on this. There is so much outside of the mortality data that people of color have to look at. When you talk about some of the demographics being different, when you talk about age being different, and maybe one of the primary ones is the fact that so many people who don't die struggle a lot with COVID, and the long haulers, as we call them, and the disparity in resources in the community to care for people that are long haulers. All of that makes any sort of a chronic issue impact communities that are unequally resourced more. And so I haven't heard anything in what you said that makes me think that, oh, I should relax a little bit because the death rates are the same. There's so much beyond the death rates that we have to be focused on. And I didn't hear you say anything about relax, Dr. Korn. I did not hear that at all. I heard you say that we have to continue to fight this particular issue as we leverage the attention on public health to attack all the other things that are out there that make us continue to have disparities in our communities. So I just want to thank you for taking the tough questions.
Sure, my pleasure. And I appreciate the questions. And I also think, and this gets into psychology, and Dr. Walks, I think, was actually brilliant in helping people understand the psychology. But, as a medical professional, talking to other mostly medical professionals on this call, there's a kinship that I feel. And, we're working hard, and we want these benefits that we've discovered and these breakthroughs that we discovered to impact as many people as possible. And so we're looking at the data, trying to use data to make everybody's lives better. And I'd love to hear that message more and more. So I do appreciate this forum, the opportunity to talk to people about it. And I appreciate the fact that we can look at data and say, okay, how do we get better? How do we deal with any barriers? And at the end of the day, also talk about the fact that we truly have come up with a breakthrough that was just completely mind-boggling when you think about it. The fact that we have effective vaccines, 3 different effective vaccines that got available in less than a year, that no one thought that was even possible. And so these things that connect us, this kinship, this fact that we're medical professionals, that we have this success, and then we want to deploy this success to help as many people as possible, to me is a really, really important message. So thank you for the opportunity to be able to express that.
Dr. Neighbor and Dr. Walks, I'd like to just ask him one more question. This data you presented has been very interesting, although a bit controversial. Would like to invite you on one of our Wednesday calls with our medical advisory so we can, as Barbara says, slice and dice it a bit more with you, with our medical professionals. Would you be willing to do that?
Sure, happy to, absolutely.
Very good, thank you. Because this call is mostly lay people, but we'd like to really get into the depths of your presentation, but thank you so much.
My pleasure.
One quick thing, Dr. Corin. I know what we're seeing in Jamaica, we saw what you said before, that it usually affects the older people. In the last 3 weeks, it's hitting our young people. I would say half my ward now are young people very sick. Are there any new variants that are doing that? Because that concerns me. I would say half of my ward, most of the calls today were under 40 for patients to be admitted.
Yeah, I'm not as familiar with Jamaica, of course. Most of what I know about Jamaica, I've learned from you, Lisa. So your observations are really, really important. But what I do look at on a regular basis is data from around the world. And so, for example, in South Africa, we're not seeing differences in mortality rate as compared to the UK, as compared to Belgium, as compared to Italy, as compared to Spain or Germany. So that would speak to the fact that the variants are probably less important. But again, we need to continue to be vigilant about looking at the data and learn. What we're doing now is so important because we share information, we share it across different regions and hopefully use that information. And just like we were putting people on ventilators early on in the pandemic, which turned out to be not a very wise thing to do, we're much smarter about how we treat people. And mortality rates have gone down tremendously because of communication and looking at data together.
Okay, thank you. Um, I guess we will talk about this in the Wednesday meeting. Are there any more questions for Dr. Corin?
Not at this time.
Thank you again, Michael, for a very healthy discussion. We do
Absolutely.
this all the time, but it's nice to see other people doing it too. Dr. Walks?
So you're going to do the intro for Dr. Despani?
Oh, to introduce Dr. Despani. Oh, joy. Let me pull the slide back up, Dr. Despani. Hold on. Okay. Dr. Despani's slide did not come up for me, which is fine. I just want to say about Dr. Despani in way of introduction, and this is something you have to be a little bit older to be able to say. Dr. Despani is just flat out a brilliant young man. Dr. Despani is someone who we look to a lot for the information that we rely on with respect to what's happening at that immunological, epidemiological, scientific, hard science level, because he can explain it to us in a way that's understandable. He gives it to us in a way that we can take and we can use. And that's what I think makes Dr. Despani special. He is a scientist, he's a leader, he's an educator, and he's someone that we pay a lot of attention to. So, Dr. Despani, please make us smarter.
Hello, I hope everyone is doing well this wonderful Sunday. And yeah, I just want to address some of the new guidelines that have come out, mainly from the CDC, as detailed by Dr. Maxey, to the basic effect that where for those who have been vaccinated, and when we say vaccinated, that means not only the first dose, but the second dose, and then having waited 14 days thereafter. After you have gotten that second dose and gone 14 days afterwards, there are now more eased up regulations, in as much as you'll now be able to meet indoors with other similarly vaccinated individuals. Although we should remain cognizant of the fact that social distancing must still remain in place. And yeah, I just have to detail that this is part and parcel of the fact that data that has actually come from Israel has, or at least with regards to the Pfizer vaccine candidate, have validated not only that there is 97% efficacy and in terms of reducing the mortality rates, but also that it actually can serve as a transmission halter, more or less. So this is very exciting news, and points to the fact that we may be putting a dent into the viral transmission rates in terms of building out that herd immunity that we still need to get to, namely between 70 to 80%. Now, that said, we should not relax by any stretch of the imagination, because as I presented perhaps a few weeks ago, there are a myriad of different variants that are in circulation. Obviously, most people typically, or at least the population at large, focuses on B117, aka the UK variant, B1351, which is the South African variant, or P1, which is the Brazilian variant. However, there are 7 native American variants that are typically in the both in the middle America as well as closer to the East Coast. And in tandem, there is now a variant in New York specifically, and another one in California, as I detailed before. And that actually underwent a viral recombination event. And just to point out that that quote unquote California variant, which should be B1429, so B1429 as well as B1427. That one essentially, for lack of a term, mated with B117, and then that created that viral recombinant in California. But just so you guys know, that original California variant, the B1429, actually originated from Denmark. That emerged earlier in last year, and that was the subject of the Danish authorities actually culling a large population of mink. So yeah, I mean, it's on the one hand, we are moving forward, but you must remain mindful of the fact that these variants have specifically evolved almost spontaneously, really, with all of the same point mutations, namely including the E44K, as well as the N501Y. So be very careful, be mindful in that we are reaching critical milestones in terms of getting the virus under control, but we're not necessarily at the end. Now, there also was a query asked by Miss Linda and Mr. John Hall to the effect that they're asking, does it look like we're going to need a shot every year? And the reality is that so long as we continue having these point mutations that act as immunological escape mutations, or even we end up having more viral recombination events, such as what occurred in California, then yes, we will start to have to focus on getting a yearly injection, which again should be no different from what you experience in your, quotidian lifestyle of knowing to get your influenza vaccine. And just to clarify, Pfizer and Moderna have already started testing, at least with regards to getting approval from the FDA to begin running the requisite clinical studies for a booster shot that will actually cover the South African variant, i.e., EG, IE being IDS in Latin. The B1351 variant. So that will be very critical in getting the really the pandemic a little bit more under control. But again, the way that both Moderna and Pfizer are able to do that is by adding that additional booster shot. And what Moderna is attempting to determine is whether they will do a third shot to the regimen, i.e. you would have to do 1, 2, and then shot number 3, or Moderna is also thinking of perhaps releasing a trivalent shot for those who haven't had any of the other vaccines. And basically by trivalent, that just means that you're going to have all of the shots, in one ready to go injection. So there's that. Now I know with regards to Pfizer is taking a different approach to, the more is better approach that Moderna is going. So Moderna is basically saying like add more to the armamentarium, do it more sequentially, or do it like 3 in 1, right? But what Pfizer is doing instead is that they're saying that for their booster shot, they just want to increase the volume of the dose that's administered. So more hearty goodness of the mRNA, the liposomal mRNA vaccine, such that you not only would be covering that E484K point mutation, but again, you're just getting more to induce that that immunological reaction. To build up both your B cells and your T cells. And then just so you guys know, the B cells are your soldiers, your immune system soldiers that are there to like spit out the antibodies that act as kind of grappling hooks that actually bind to the virus and then hopefully neutralize it basically so that it's frozen in place and it can't do anything. By contrast, the T cells are actually think of them almost like immunological or cellular Navy SEALs, in that they actually patrol each, in the nooks and crannies in the interstitium, basically the nooks and crannies, for lack of a better term, of the cells. And then once they identify a cell that maybe is looking weird, and by looking weird, basically its plasma membrane is maybe budding off the SARS coronavirus 2 variants, it says aha, and then it subsequently latches onto that infected cell and starts to release a series of different enzymatic like perforins and things like that, enzymatic components that actually induce what's called apoptosis. And apoptosis is another term for cell death. So that's programmed cell killing, to basically, like, you're infected, you have to go, we have to keep everything under control. So that basically provides a very nice overview of what's actually going on. Because, obviously people are like thinking like, oh my God, we have to get this vaccine and it's going to be great and whatnot. But let's dial down a little bit further. And like what you're really having occur is a battle being waged between the virus and your body. And you have to do everything in your power to equip your body to have the weaponry, the armamentarium, the tools in order to actually combat that virus. So that's why it's critical for the Black community to get the vaccine. Now, again, I follow what in Latin is called the mediocritas aurea, the golden mean. So I do believe to some extent that we do need to get more members of the Black American community to get over their I guess fear of getting the vaccine. But it also is that there are other cases, and we have seen this in the news, that vaccines have been allocated to poor areas and poor zip codes. And the fact of the matter is that some of those instead just get magically misallocated towards wealthier zip codes and whatnot. So again, that golden mean, that there's a good balance to be understood between, one, there are many in the Black population that do want to get vaccinated because they know specifically that they're at risk. They have that sword of Damocles hanging over their neck. But then in a similar situation, there are also others that, again, do have vaccine hesitancy. And I know this for a fact, precisely because I have some of my own friends who they know supposedly how brilliant I am, but they still have that vaccine hesitancy. And their I guess, explanation is that they're like, wait, like no vaccine has ever been approved in such record time. And then again, like Dr. Corin detailed, I also have to always mention to them that this has only received emergency use authorization. And that's why it's always incumbent to realize that it's a process to get any type of candidate, whether it's a small molecule drug or a biologic or vaccine, blah, 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 to get approved. So you go through phase 1, you go through phase 2, you go through phase 3. People think that it's over after phase 3, and that's absolutely incorrect. Rather, what you do is you subsequently have phase 4, where the drug or the vaccine candidate or what have you is actually in the public, but it can actually be withdrawn for any reason, for adverse effects and whatnot. So just know that there always is that post-approval surveillance going on by the FDA. So, I mean, that case in point, that's actually why thalidomide was actually withdrawn from the market, because despite the fact that it was actually a very good, to a certain extent, it was good as chemotherapeutic applications and whatnot, it was not good for morning sickness to treat pregnant women. So again, the FDA swooped it back up and said, absolutely not. So yeah, I mean, it's just all, it's all an ongoing thing, right? We're dealing with a multifactorial, problem, and it takes time, and really it's an ongoing issue that we have to deal with. But yeah, that's why you have people. Okay.
So Dr. Despani, I want to thank you, and I wish you were around when I was in medical school trying to learn immunology, because anyone who can put the sword of Damocles, a Latin quote, and nooks and crannies all in the same presentation that people can understand really needs to be doing a whole lot of teaching. So thank you for that. It's complicated, and it's challenging, and it's understandable, and it makes a difference when we're trying to really communicate to folks. Let me just one little comment. When I hear vaccine hesitancy, I hear a conversation. And I don't want anyone to tell me about vaccine hesitancy unless they're talking about someone who actually refused the vaccine, not someone who had a conversation about the fact that they may not like it and they're worried about it. So if we urge people to say vaccine hesitancy means that you hesitated when I had it, I offered it to you and you said come back later. That's hesitancy. It's not that I had a conversation and I was worried about whether I should believe Dr. Despani or Dr. Walks or Dr. Maxey. That's not hesitancy, that's a conversation. And we want people to have conversations. So with that, Dr. Nabrit Stevens, I'm going to turn it back over to you because if not, I'll just keep talking.
We'd love for you to talk, Dr. Walks. So, if it weren't for the clock on the wall, I'd say go at it. But we are going to be sensitive to everyone's time. I want to thank all of our panelists that have participated today. I certainly have been very stimulated. And as I started the program off with the comment that this is something new every day and we have to stay on it,
Right.
I think you see now why we have to stay on it. Next week, we are going to have a program addressing mental health needs in our community, led by Dr. Ron Bailey. We're looking forward to that conversation. As you may have heard, if you were following the ins and outs on the COVID bill, there's significant money that is being designated for mental health services. Not a minute too soon. And we will, I'm sure, have a stimulating conversation next week. At this time, I'd like to call for our aspirational moment, if it is available. Ms. Ager?
Good afternoon. Can you hear me?
We can hear you.
Yes.
Oh, good. What a day this has been. Oh my goodness, the infamous. And Dr. Smang, I don't know where you came from, bro, but you're an amazing, amazing creature. So I'm going to do my part and just sing that I know what to do with me. Make a joyful noise unto the Lord. All ye lands, let us be in one accord. All ye lands, so I will sing for you. I will speak your truth. I will dance your joy in everything I do. I will lift my voice. I will sing your praise. Lord, my whole life long, I will be your song. And in this moment of love and knowledge, we just give thanks for our time together. And we speak a word of all of us being healthy and getting back here next week. Until we meet again, thank you on behalf of Black Health Trust. Thank you all the doctors and Dr. Barbara, everyone. Thank you so much. Dr. Walks, everybody. And Dr. Randall Maxey, thank you and God bless you, man. Dr. Corn, everybody.